We're going to start with two, yeah.
Okay,
And
perfect.
we'll do two more later. All right. Well, I wanted to welcome everybody to Mount Sinai. We're here in room one. I wanted to thank my amazing nurse and technology staff. I'm actually standing next to Dr. Shilo here on my left, and Dr. Carlone, who's our chief resident, and one of our PGY4 residents behind me, Dr. Dada. Tim is going to present the case for you guys, and we have a couple interesting cases today. This is the first one. So if you guys could put the slides up, that would be great. Thank you.
Great. Thank you, Dr. Fishman. Happy to be here. So I'll just jump right in. Next slide, please. So we have a 33-year-old woman here who initially presented with flank pain associated with gross hematuria over the course of about a year. She's a distance runner, a heavy runner, and she noticed her symptoms, especially the hematuria, were exacerbated by running. She had a pretty extensive GU workup done, including a CT urogram, which was unrevealing, and a cystoscopy. On the CT urogram, there was some concern for left renal vein compression, which was confirmed on MRV. Past medical history, she has a history of Ehlers-Danlos and thyroid cancer, status post-thyroidectomy, social history, allergies, medications, as are up there. Next slide, please. Vitals, unremarkable. Her exam, worth noting in particular, she has no CVA tenderness on exam, and then she does have some increased laxity in her joints associated with her Ehlers-Danlos. Labs are within normal limits. Next slide, please. So this was her MR venogram. We'll run through it quickly, and then I have some still shots. So as we're coming down, we can see the left renal vein coming across, and it is compressed between the SMA and the aorta. Looks like it will not play again. But also, next slide, please. Also worth noting, she does not appear to have a dilated gonadal vein on this side. And so that's just a zoomed in still shot of the compression. Next slide, please. So we initially performed, when she was referred to us, we decided to perform a diagnostic venogram and an angiogram just to better assess this. We performed IVUS at the same time. So the left side image, we have the venogram. We can see kind of delayed outflow and filling of that lumbar collateral. We do not see a large gonadal vein, though, and so most of the decompression seems to be happening via small lumbar collaterals. In the middle image, you can see that stenosis, and then on the left side, on the right side, the lumbar collateral. Next slide, please. We also did an angiogram at the same time, which was normal. Next slide, please. So IVUS on our initial images, we show a very, very tight stenosis, which you can see in the middle of this slide, compared to a relatively normal renal vein and IVC on the other sides there. Next slide, please. Next slide, please. So in summary, this is a 33-year-old woman with a year of left flank pain and gross hematuria. She has an MRV showing compression of the renal vein, which is confirmed on venogram and IVUS. We also have a 5 millimeter of mercury pressure gradient across the stenosis and normal angiography. So overall, the constellation is strongly suggestive of nutcracker syndrome. So after the first venogram, we had a long discussion with the patient. She was also evaluated by vascular surgery to discuss open intervention. And she opted to return for a repeat venogram prior to any other intervention. So with that, we'll sort of jump into the case and kind of discuss what we've done so far and what the plan is.
All right. So I'm going to put up the venogram we just did so you guys can see where we're at. And I'm hoping that the panel will comment on what they see on this venogram. So I'm just going to let this play. Oop. Sorry. Here we go. So, Kush, what do you think of this venogram?
Yeah, it's interesting. Nutcracker is one of those things I think is frequently invoked, less commonly present, but this is actually a pretty clear case based on symptoms. Certainly you have flank pain and hematuria, and that's what I look for in any patient with a so-called renal nutcracker renal vein compression and pressurization of the renal reservoir. The other thing you don't see here, which is interesting, is there's no ovarian reflux. And when you have ovarian reflux, that maybe changes how you think about approaching this. But the presence of the hilar collaterals is, I think, the striking part here.
Yeah, and when you see gonadal reflux, a lot of these patients will present with pelvic congestion type symptoms. We actually have a case in the next room, which you guys will see, which is not nutcracker, but similar. I think for somebody like this, where the main complaint is hematuria, it does make sense that the veins within the kidney itself are not decompressing via a large collateral. And so that potentially is one of the reasons why we have this gross hematuria, which is pretty frequent for her and very life-limiting. So we talked about stent placement here. We had her see one of the vascular surgeons who discussed bypass. And without a gonadal vein, the bypass is slightly more complicated because a lot of times they'll use the gonadal vein and use that as the conduit and go directly into the IVC instead of actually dissecting around the renal vein. But in this case, we don't have that. And so our thought was to be as conservative as possible. We probably won't place a stent today because what we were thinking was that we would potentially angioplasty this and see if she gets any relief, even if it's for a couple days. That would indicate that this is probably the reason that she's having the hematuria. Her urology workup was completely negative and very extensive, so we really don't have any other reason why she'd have hematuria. So any other thoughts from the panel before we show you guys the IVUS?
Hey, Aaron, this is Vikram. Good to see you.
Hey, Vic.
So you said you were.
How's your fantasy football team doing?
Hey, I'm still in it, so we'll see how it goes.
All right, we'll see.
So you said you're not going to stent here. If you were going to stent, can you walk me through your thought process of like how would you land it, how would you size it? Because on the angiogram, on the venogram, it's hard to see precisely where the compression is.
Yeah, so we're going to run the IVUS. Actually, Dan's going to run the IVUS while we talk. So let's show the IVUS, and we'll hit live on the IVUS, and we'll talk about that. Obviously, you want to have the stent land into the cava, but you also have a size mismatch, as you guys can see, as you sort of get into the renal veins because they're smaller. And so, this is a very treacherous place to put a stent for lots of reasons. One is the size mismatch. The length of the stent is usually very short, and so if you don't land it perfectly, it may move. There have been reports of obviously stent migration to the heart with cases like this, and so this is not something that we take lightly. The stent obviously has to be positioned perfectly. We marked on the IVUS, and you guys can see the live IVUS here. We marked on the IVUS, usually on the screen, and we sort of take a couple of different snapshots just so we have we've double checked where we think the highest grade of the compression is. In general, in cases like this, I've used 14 millimeter by 40, but I know there are some cases where you could potentially use shorter. I just find it very difficult to land a shorter stent than that, especially a self-expanding, which would probably be the best option in a case like this. But obviously I'm curious to hear what everybody else has done from a stenting perspective for this.
Windsor has a comment.
Hey, Windsor. You guys can see the IVUS and where we actually are.
We can, yeah.
You can see it, yeah, good. And you can see the live fluoro as well?
Yes, we can.
Okay.
How do you know this is pathologic? And because if I do the IVUS in the renal vein in a normal person, wouldn't I see similar kind of compression? The renal vein is dripping over the aorta. The aorta pulsatile is pretty big. Wouldn't you see some narrowing? When do you decide it's pathologic versus just a normal finding?
Well, if you go back to the venogram, I'm going to pull that up here. This one. This is an abnormal venogram, Windsor, and I think yes, everybody has some degree of compression, but this is more than what we would typically see. Plus, we see lumbar collaterals filling, and then given that she's had flank pain and gross hematuria with no other cause, this is more of a diagnosis of exclusion. I mean, we would love to have another reason for her to have hematuria, but we just don't. She's had cystoscopy, she's had CT urography, and she's been fully evaluated by a urologist. So we don't really have any other reason why she would have hematuria. And given these constellation of findings, this is the most likely diagnosis, in my opinion. But I'm not convinced, and that's why I'm not jumping into putting a stent in this patient right now. I don't typically balloon venous compression and as a treatment, so this was more of a diagnostic venoplasty. But again, I'm sort of curious to see what other people have done in situations like this. Let's get the balloon ready.
Have you considered measuring pressures? Is there a role for pressure?
We did that already when she came in for her diagnostic venogram.
Let's take the IVUS out first.
And we had about a 5 millimeter gradient across that IVUS lesion. So, I don't know how significant venous pressures are. Vic and Kush, do you guys have any opinion on what a significant venous pressure gradient would be across this type of stenosis?
I think that's significant. 5 millimeter mercury venous pressure gradient is significant because venous pressures are very
I
low.
thought it was significant, but I've seen higher, obviously.
Yeah,
But in
yeah,
a case like this, where it's sort of subtle, let's take that out. We'll just get back in. So we started out with a Rosen wire, and we were not getting a lot of support, and so what we put in was a stiff of short flop amplats. I use this a lot for cases where you have very short purchase. The problem with these stiff amplats is that they're very long and they're sort of hard to work with. So we're going to just get back in real quick.
Yeah, some of the, what Aaron brings up is true. It's really difficult to treat these cases just because you have very little room to park your wire. And so sometimes what I'll do is actually catheterize the ovarian vein. So because the compression is always going to be central to that. And then you can get, you're only working over the stiff part of the wire. But that's assuming that the ovarian vein is a little bit dilated. And here it might be difficult because it's not terribly well dilated here.
No, and we tried a little bit to get down the gonadal vein, but it just sort of ends very abruptly. So we're just going to leave it in the renal vein and just try to get a balloon across. What do you guys think about balloons? Well, let me ask you another question. If you were going to stent, what type of stent would you use here, given what you've seen so far?
Yeah, I think you're right on a short self-expanding stent. I'd use IVUS to measure not necessarily the lesion. I think the lesion, just more of the position of the lesion, but you're going to want to measure where it anchors centrally, and you don't want to be undersized relative to that because that's when you run the risk of it flying. So I'd have to go back to your IVUS to see what it was to have an idea, but it's typically, 14, 16, something like that.
Yeah, so we're going to start with we have a 1440 Athletis, which we're going to start with. I'm sorry, 1240, not 1440. We don't have a 1440 Athletis. We actually have a 1440 Atlas, which we could consider using. I just don't love that balloon for this because the shoulders are a bit big. What are your thoughts on that balloon?
Yeah, I mean, broad shoulders on an Atlas, right? That's the concern. The Gold has the Gold has narrow shoulders. It's a little bit easier to use. Actually, didn't realize Athletis came in a 14 millimeter. I thought it only went up to 12, but
no, sorry, 12. It's 12.
Okay,
this is what we're going to put in now.
Got it.
So we have that stiff amplats, that short 1 centimeter flop. So hopefully this gives us a little bit of purchase. It's a 260 wire, so it's a little bit challenging to use, but it looks like it lined up okay here. We also have a 10 French sheath just to give us a little extra support. So it's 30 centimeters. I like that lineup here. So we're going to try to go slow with this venoplasty here and see if we see any waste at all under fluoro. I'm going to zoom in so we can take a better look here. Yep. Just going to watch it real closely. See what we see here. What do you guys think?
Maybe a little bit there.
Subtle.
Yeah.
Subtle. Yeah.
A little bit. It still feels small, this balloon, relative to the vein size. But again,
Are you able to move it at all?
the native vein is not much bigger than this, and if you have a 12 millimeter renal vein, you should be able to decompress your kidney adequately. And so, if this was a stent, I would probably go a little bit bigger.
Yep.
I'd probably go
I
for
think
a
we're
14.
undersized here. I think we can move the balloon a little bit.
Yeah.
One of the other things we were discussing is potentially, just like running a Fogarty to look at it, to kind of get a visual. But we have this,
Leave it up.
and we're not getting much of a waste. There might have been something subtle there in the very beginning, but obviously we're fully up now.
And you might not get a waste, right? I mean, if there isn't any scar at the compression site, you might not get a waste. You'll just be elevating the artery off of the vein.
Do you feel any pain? Yeah. You're hot? Okay. No, do you feel any back pain or anything back there by your kidney? Okay. Okay.
With this balloon
All
up, are you anticoagulating her?
We are. She's heparinized. All right, so we left this up. We're going to leave this up for about a minute. Yeah. And then what do you guys think about IVUS, repeat IVUS versus a bigger balloon here?
I think I might do a run because you want to see if I at least want to see if you have any diminution of those hilar collaterals.
Yeah. Okay. We're gonna put the MPA catheter back in and do a run through that. So we're gonna take the balloon out now. I could potentially do a run through that sheet and try to get it to reflux, but I really don't want to put that sheet down if we don't have to. What stents have you guys used for venous compression in the renal vein?
I'll be honest, I haven't done too many of these cases, but if I was going to think of a specific stent, certainly a self-expanding stent that we were talking about. Do you guys have any favorites that you'd use?
I haven't done any much of these cases, but yeah, self-expanding, short stents. I guess you can take your pick of which brand.
Yeah, I think you can take your pick of the venous specific stents.
Yeah, I've done several of these before the venous stents were approved, and so I've used smart stents. 1440 is probably the most common size that I've used.
Sure.
It's a little bit tricky to land a 1440 smart stent. They have a fair amount of stored energy when you release it.
All right, check it out.
I think now I would probably consider some of the newer stents. All right, so here's our run. Zoom out.
Let's actually get this sheath a little bit out of here.
I'm gonna zoom out more.
So probably shouldn't be surprised that it's still there, right? But
No. I mean, I think a definitive treatment for this would be a stent. This is, the hope here. And again, I don't know that this is even going to work, but the hope here is that Petey, she gets some relief from the hematuria, so we can be sure that before we put the stent in, that this is what she has. I think we're going to try a 14. Let's grab that 14 balloon over there, the Atlas. We're trying not to keep that too far into the renal vein because the size discrepancy that you guys can see that there's a big difference in size, and so that's why a self-expanding stent here makes sense. If you're going to put a stent, I mean, some people I have seen some people put in balloon expandable stents, but the sizes don't really make sense for renal vein in my view.
I would agree with that.
Here you go. So
You're good.
we're going to put the 14 in. We'll balloon that up to profile, and then we'll do another venogram. We'll do another IVUS. And then hopefully we'll have some follow up in a few weeks. And then if she does get some relief, then we'll probably end up putting a stent in. And I spoke to her vascular surgeon who she saw, and he's completely willing to do a bypass and remove the stent if necessary. So if it comes to that.
It might be interesting to also, after the IVUS and run, when we're done, to just do a pullback pressure and see if there's any change there.
Yeah, we'll probably we could do that for you, Kush. That's not a problem.
Yeah, we'll take one off the.
Can we get a pressure transducer?
Don't open it on my my account only.
I have a hard time detecting pressure differences in veins, especially when it's less than 5.
Yeah.
I'm probably not going to use a pressure wire for this. We'll just use a transducer. But it would be useful just to see if we had any impact on the gradient at all.
Nowhere.
All right, so this is the Atlas is a good balloon, but it's not really made for renal veins. So we'll see. That shoulder's quite big, huh?
Yeah,
All right,
Let's do that. Yeah.
that looks pretty good.
All right. So
What do you guys think?
Yeah.
Pull back a little bit.
No, I think you're good there, actually.
You like it?
I like it.
This is a great balloon, but not made for a renal vein.
That's part of the problem, right? We're kind of cobbling stuff together to treat these patients. Don't have devices that have been
Oh, look at that.
There you go.
Yeah, we found it. So it just needed a bigger balloon. That's something, huh?
Wow.
Yeah,
Tough.
it's there.
Is there pressure at?
Is the patient feeling this at all?
Do you feel any pain? You felt a cramp. Where did you feel the cramp exactly? On your left side? Okay. All right, let's take that down. What pressure did we get up to? So that was at 8 atmospheres.
Okay, yeah, so but the nominal profile.
So that's interesting how you go from a 12 to a 14 and you don't see anything on the 12, what you do on the 14. I mean, that happens sometimes with, when you undersize balloons, as we've known from, DVT and other cases that we're doing venoplasty. But pretty interesting. So what we're going to do now is take the diagnostic catheter down, and we'll do the pressures and the final run.
I got it.
Hopefully we didn't lose access.
Yeah, we have a question to the audience. Can you, the mic?
I'm a non-interventionalist. I'm a cardiologist. Since the compression is extrinsic, it's not intrinsic in the vein, isn't it very likely?
Is that pain gone?
Yeah, that's so.
The pain go away?
The problem here is that this is all clinically
Good.
derived.
I think you're going to demonstrate that it is likely the cause of her symptoms and her problem.
Right, exactly.
It's not definitive therapy because it's extrinsic.
Right, exactly. So this is partially a diagnostic maneuver.
All right. Pull the wire.
Not stented today.
That should be good to do the run, right?
Yep.
Young patient putting in a permanent prosthetic, want to be absolutely sure there isn't a purpose-built stent for this application. If you're going to place a stent, you want to make sure that you've eliminated all causes right here. And as Aaron had mentioned, stents
Looks better.
run the risk of migration
Good
here.
DSA.
Are the stents that you use in veins more tactically different than arterial stents?
Much more higher outward radial force.
Are they sirolimus?
No, they're not coated.
Okay.
No, they're bare metal.
So, do you want to do an IVUS or do you want to just do a pressure?
I think we do pressures.
Okay.
Do one off the sheath, one off the catheter, and that's it.
Yeah. All right. Let's hook this up.
Just another question about when you stent these cases. Do you stent across, if there is a gonadal vein, do you stent across the gonadal vein, or you don't want to gel the gonadal vein? The second thing is that
You try not to, Windsor.
so you put it
in general.
proximal to the
Yeah. Yeah, you would try to, but in this case, I don't know how feasible that would be. The open cell design would allow you to come into the gonadal if necessary, and if they do need surgery in the future, the stent could be removed and the gonadal could still be used, even if it's across. But ideally, you don't want to cross the gonadal vein. Sometimes in cases like this, what we'll do is we'll do a gonadal vein embolization if their main complaint is pelvic pain, and usually that resolves their symptoms. Sometimes what you'll do is you'll get. Can we zero it? We zeroed it. Sometimes you'll get hematuria after you do a pelvic congestion embolization in somebody with nutcracker because you're forcing, the blood back through the kidney.
And that's actually what I was going to bring up because, a lot of these patients come with the diagnosis of nutcracker based off of just axial imaging, but they have a large ovarian vein that's refluxing, and they don't have hematuria. They don't have flank pain. They have just pelvic pain from uncompensated ovarian reflux. And so if you treat the ovarian reflux, their symptoms go away and the compression is not physiologically relevant.
It's very interesting. We don't see this very, very often, and so that's why we wanted to show this case today. There's lots of different ways to think about this, but ultimately we want to be really careful about what we're doing before we put a stent in. But I'm a little bit encouraged by that waist there, by the fact that she felt that pretty significantly when we did that balloon. And there's no gradient right now.
Yeah, there's 0 gradient.
We got 5 and 5, so we're good.
Yeah.
We're gonna do one final run right proximal to where we were. So we're going to try to direct it not in that collateral to see what the flow looks
Yeah, we'll
like.
pull back a little bit.
Yeah, just a little bit. Yeah,
Maybe a little.
maybe there. Just to see if the flow. It's, I again, like you were saying, Kush, I'm not that worried about the venogram look. It's more about the pressure in the IVUS.
Right.
Yeah, I think that venogram is a little bit deep in. I think this might be a better shot.
We'll see. Maybe this will give her relief. It does look better to me,
Yeah.
Wash out.
subtly.
It's flowing faster.
Yeah. Well, hopefully that was educational for everybody. We'll give you follow-up in the next couple of weeks. We'll see what happens with the hematuria, and if it goes away, then we have our diagnosis.
Real quick.
So we have a case in the other room. I don't know if they're ready, but if you guys have questions, we're happy to chat.
Yeah, real quick. If you do place a stent, what is sort of the medical management surrounding that stent? Do you anticoagulate them for some period of time?
No one really knows the answer to that. I think with large stents, you don't have to. I would probably consider aspirin though for this patient if we were gonna put her on a. You could also consider Plavix, but I think that might be overkill for a large venous stent like this. Well, what would you consider, Kush?
Yeah, I actually probably wouldn't anticoagulate these patients because the flow, the kidney gets 20% of the cardiac output split between the kidneys, and there's so much flow through the renal vein. I think I'm in agreement with you. Very little is going to happen.
Yeah.
Even with your aspirin, how long would you
it's-
do aspirin for? Just a couple months?
Yeah, probably a few months, 3 months maybe.
I
Again,
think
that's
of
not
this.
based on anything. That's just my.
I kind of
my
think
own
of this like
gestalt.
non-thrombotic disease, and there's disagreement on this, but when I treat non-thrombotic patients, the May-Thurner without any antecedent DVT, I don't anticoagulate them, and I've yet to see
Yeah.
an issue.
Do you guys know if they're ready in the other room? Okay.
Any-
They want to do a talk? Okay.
Oh, okay.
You guys have any other questions?
Yeah, I guess we talked about stenting across the gonadal, but what about on the caval end? Are you concerned about entering the cava with this stent at all?
I sort of think about it the way we think about it with iliac vein stents. You want to have some into the cava, but probably not more than halfway in, just to allow enough room for the other renal vein to not be compromised by the stent. But it's completely fine and appropriate to put maybe a third of the way into the IVC, and that's probably what I would do to anchor it. Depending on the length of the renal vein, you could consider even a longer stent. And the reason I would do that is because landing a 14 by 4 self-expanding stent is very hard, and there's several case reports of them ending up in the heart, especially if the lesion narrowing is not dramatic. You can see in this case it's not as dramatic as we've seen in previous cases.
Aaron,
So,
if we're still waiting for the other room, can you go over how you would follow this patient up, whether you would do imaging and how you would see them, that kind of thing?
Yeah, sure. So I'm going to follow up with her in a few weeks and see if she has any hematuria or if it's improving, because she runs a lot. And so it's almost every time after she runs that she gets hematuria. So we'll find out pretty quickly whether this particular intervention had any effect. And then we're going to have a discussion about stent placement after that. And she's pretty clear that she doesn't want to have surgery right now. And so if we're going to do something, it will be minimally invasive. So it'll include a stent. I'm just sort of curious how, what type of stent you guys would use for this. I mean, I was thinking more of like a 1440 smart stent, but I could be convinced otherwise based on what I just saw here, because that 14 balloon was probably the right size, and we'd probably want to oversize it more than that.
What did your IVUS show for the size of the central renal vein?
We got about a 14, right, Tim, on the IVUS? Yeah, so we'd probably want to go bigger than that, right, Kush?
That's that's a difficulty, right? Because you're probably closer to 12 centrally or peripherally, and then closer to 16 centrally. So, yeah, you might need a 16 or a longer 14, like a 60.
Yeah, like a 1460. Yep.
Is this ear supposed to be on
yeah.
or no?
That's the challenge.
No,
We
okay,
don't really
okay.
have stents that go for this, so we have to sort of just go with what we have. But again, we have more choice
Okay.
than we used
Do
to.
you guys
But
Yeah,
I'm just,
tested or
a lot of these cases we've been,
Okay.
we've been basing this on our previous, our
Okay,
previous
sounds good.
knowledge of what was available.
And
Now we sort of have other options.
am I
Um,
allowed to hear anything, or
think
am I going to hear anything?
Kush, they're asking if
I
you
don't
guys
hear
can do
anything
one
right
more
now.
talk before the case because they just need a few extra minutes. Is that
They need a few
reasonable?
extra minutes? Sure. We're done with the morning session, but we could
Okay, now
probably start the.
I can hear it. Can you put the volume a little bit
We're
higher?
hearing some crosstalk from the other one.
I think we hear the other room. Yeah.
'Cause the volume's pretty low.
Okay. Well, great. Thanks, Aaron. We'll
Thank
catch
you,
you a little
guys.
bit later on.